Good evening, everyone. Welcome to a collaborative education session with Vanderbilt Behavioral Health and NAMI Davidson County. I am Don Liacano, the Chief Program Officer at NAMI Davidson. Tonight's presentation is going to be about electroconvulsive therapy and transcranial magnetic stimulation. And for further introduction, I'm going to pass it along to our community partner at Vanderbilt, Tracy Glasgow, to introduce our presenter tonight. Tracy?
Hey, thank you. It's so good to see everybody tonight. And I'm excited that you get to hear this wonderful presentation. I've had the opportunity to hear it before, and I just thought this would be a great topic with a lot of interest. We're going to be hearing tonight, and I know I'm going to mess up your name, so you're going to have to help me, Tim Adegoke. Okay.
Yeah, pleasure to be here.
Yeah, thank you. Thank you. Thank you. This is he is our assistant professor of clinical psychiatry and the medical director of our neuromodulation services at Vanderbilt Psychiatric Hospital. And I want to go ahead and turn it over to him because we're going to have a very informative and interesting presentation tonight. Thank you.
Thank you, Tracy. So really excited to be here talking to this audience. And Don, thanks for having me. We had a little chit chat about the organizational structure, and I was telling him that NAMI really has an outsized influence, on mental health in Davidson County and beyond. So kudos to you for all you do. Really appreciate, everything that comes out of NAMI. And I hope today will be educational for most of us in the audience.
Thank you.
Sure. So Tracy mentioned that I'm the neuromodulation director at Vanderbilt. Some of you might be wondering exactly what does that mean, neuromodulation. So I'll ask you to stay tuned. I'll really break down what the elements of that umbrella term are. But spoiler alert, I really am going to be focusing on electroconvulsive therapy and transcranial magnetic stimulation, which are a type of neuromodulation. Okay. But I did want to start with some basics because we all know that neurons are the building blocks of our nervous system. If you're looking at your screen, you'll see this little figure that has essentially what looks like twigs and branches. So that's really how the basic building blocks of our nervous system are. They're basically nerves with branches that connect with other nerves. But beyond those individual blocks, we also have what we call neural circuits. An example is the fact that you're listening to me right now. It means that there's a circuit involving a neuron that ends up in a certain part of your brain that is involved in hearing. So that's an example of a circuit. And what we know about circuits is that they can be interrupted. For example, if somebody had a stroke or some other type of injury, we could see a very clear lesion that you might even see on an MRI that shows that this circuit has been broken. And because of that, we have a symptom like hearing loss or vision loss or something of that nature. So that's one example of how the nervous system is organized and sort of a closed circuit that can be interrupted. However, there's a deeper level to the nervous system, and that's what we call the neural networks. Okay. And this is why it's really hard to know what the causes of mental illnesses are, because it involves such a complex interweaving of multiple circuits. But we are able to study these a little bit better now because we have functional imaging and some other innovations that allow us to actually figure out what might be going on when an individual has a mental illness. The other half to that is now we can actually intervene by doing certain things that can tip the balance in these neural networks one way or another. So that's what I'm going to be talking mostly about. The other concept I thought to bring up is this concept called neuroplasticity. I'm sure we've all heard this term thrown around. Essentially, what this term is getting at is the brain, the neural networks I just talked about, they exist in a certain state of balance, right? To where if nothing changes them, they just stay in that state of balance. But things like stress, things like trauma, neurodegeneration, a number of things can tip this balance in a negative way, which can result in psychiatric illness. So there can be positive change as well as negative change to the function and the organization of the brain. So that's the idea behind neuroplasticity, that the brain actually can change, and that can be for better or for worse in either direction. So different ways that we can promote positive neuroplasticity. Psychotherapy, as we know, is something that actually leads to change in the brain, which a lot of people don't realize, is that psychotherapy helps rewire the brain in a lot of ways. The same thing happens with our medications, the antidepressants, antipsychotics. These also help to rewire or reorganize the brain in terms of their function. And then the sort of evolving mechanism to cause neuroplastic change is all the neurostimulation methods that I'm going to talk about. And then also just in terms of mental illness, what really causes them, it's a really complicated interplay, right? We talk about nature versus nurture. We all come with our inherent vulnerabilities, our genetic makeup, our temperament, things like that. That's sort of the foundation, which can then be affected by psychological stress, environmental exposures, things like inflammation, neurodegeneration, and what have you. But the idea is, regardless of what's going on, the final common pathway, what it all boils down to is there's some change in the balance of our neuronal networks. And that's something that we can try to reverse or modify. Okay. And like I mentioned, psychotherapy does that. It does lead to changes in our neuronal organization. The medications we use, the SSRIs, SNRIs, they also do the same thing. And then a lot of us might have heard about some of these more novel pharmacological agents, things like ketamine, psilocybin, ibogaine, things like that. These are more novel agents, but they really also induce neuroplastic change in the brain. And then I'll talk about ECT, I'll talk about transcranial magnetic stimulation, which are non-invasive methods of inducing neuroplasticity in the brain. Okay. There are more invasive methods like vagal nerve stimulation, which is FDA approved for treating depression. There's also deep brain stimulation, which involves placing electrodes very deep in the brain. That's for treating OCD. And then there's something called psychosurgery, which actually involves using what's called a gamma knife, some type of radiation to cause certain lesions in the brain. Again, this is helpful for treating OCD. So this is sort of the scope in terms of, all the treatments that are out there. And the ones that involve things like ketamine, things like ECT, VNS, those might be the ones you call neuromodulation. In some centers, they call that interventional psychiatry. So I just wanted to give a broader overview of all the treatment options that are out there. And then, just because pictures are worth thousands of words, I wanted to show you an example of what one of the agents I just talked about, which is ketamine, what it actually does to the brain. So this is an electron microscope scan of, and this is in a laboratory setting. So this is actually the brain of a mouse. So we see the control on my left to where the nerves were of a certain size. And then 21 days of going through stress, we see that there's a lot of thinning of the nerves to where there's a lot of atrophy. It just doesn't look as robust as the control, right? And then after 1 day of ketamine, we see that the neurons have, again, regained their robustness. And so this is basically neuroplasticity, in black and white. That shows both the impact of stress on our brains and our neurons, and shows what treatments like ketamine and ECT and things like that, what they do, which is essentially restore the robustness of our nerves and help them communicate more effectively with each other. So I just thought that picture is worth seeing. The other thing I want to touch on is this concept of treatment-resistant depression, just as an example of something we might treat with ECT or TMS. So the first thing to say is there's not a standard definition of what this means. Typically, it's insurance companies that define what they mean by treatment-resistant depression. However, the idea is the individual has tried multiple treatments, usually 3 to 4 antidepressants from at least 2 classes, and used it for a sufficient amount of time. So sometimes they define that as 4 weeks, sometimes 6 weeks, but basically an adequate dose and duration of an antidepressant. And in spite of that, the depression is not getting better. So there's no response or there's no remission of the depression. So I'll add that, trying a medication and having it be poorly tolerated, having some side effect or the other, will also be counted towards that number. So you can get to treatment failure by either using the medication for so long and it's not working, or you try it and then you have side effects that make you have to stop it, essentially. The other thing to mention is that psychotherapy is usually required, because we know that both medication and psychotherapy, these are both first-line treatments for depression, right? So it's expected that some amount of evidence-based psychotherapy has been tried during the depressive episode that we're talking about. So this is essentially what constitutes treatment-resistant depression. And the implication is if you have a treatment-resistant depression, then insurance will pay for some type of neurostimulation-based treatment like TMS or ECT. Okay? I will say that there's a concept known as pseudo-resistance, where it's really about not trying medications for long enough. Because as we know, SSRIs, SNRIs, medications of that nature, they take a while to exert their effect. Again, because they have to induce this neuroplasticity in the brain. Yes. So in terms of the ways that treatment resistance can be diagnosed, it could be failure of response. Like I said, using it for long enough, 6 weeks, 8 weeks, and there's just no improvement in the depressive symptoms. But sometimes there is a response and the response is just not sustained. So folks might relapse very quickly, even if a medication works. And like I said, poor tolerance some people actually have the medications work, but then they have side effects that are prohibitive for them to where they just don't want to be on the medication anymore. And then there are also a lot of other complex factors. We know that some people, may have depression, but also have PTSD. Sometimes there are personality disorders and other things that are untreated that would essentially make the treatment of the depression very complex and difficult to treat. So these are different ways that we can arrive at the definition of treatment resistance. And, there are different approaches to take. Next thing I wanted to share about is this landmark antidepressant study called the STAR-D study. I don't want to bore you with the details, but the headline from that study is that at least 33% of the general population have what we would term treatment-resistant depression. And the more medication trials are required to get to remission or response, the harder it is to treat the depression, okay? So if you started out with a pool of 100 people, you tried the first medication, you would have maybe 37% respond. And then of the balance, if you had to try a second one, even fewer people would respond, and so on and so forth, okay? So all that to say, there's a large population of people out there who struggle with depression, and they have what would qualify as a treatment-resistant depression. And then the more medications they try, they might not have much success. So that might be something that's very depressing, very discouraging. But thankfully, we have treatments that are tailored towards exactly such a population of those who have the treatment-resistant depression, which I will talk about subsequently. So beyond depression, there are other conditions beyond major depression that can be treatment-resistant. We know that some people have bipolar depression that's also very treatment-resistant. And like I said, it might be just relapsing very frequently or not recovering fully from the depression. There are different ways that you can be resistant to medications. And then it's also very common for people with schizophrenia, schizoaffective disorder. That's what we call the primary psychoses, primary thought disorders. Some of those, some people who struggle with this just do not respond to medications. And that's when, things like ECT become an option. OCD is also another condition that we tend to have a lot of treatment resistance. It's actually in probably the 40 to 50% range, even higher than depression, to where medications don't work. Even when they work, they take much longer to actually lead to remission or response. And then you might have heard of people who become catatonic. Catatonia, the way we think about it, it's not a primary disorder on its own. It's usually secondary to something else, okay? So catatonia can complicate depression. It can complicate schizophrenia. So usually there's something else underneath, but then catatonia is basically a marker of severity that tells us whatever it is they have is very severe. That's why they get catatonic, okay? So that's another condition that could be very treatment resistant and require an advanced therapy. Okay, so let me start with talking about ECT. So ECT stands for Electroconvulsive therapy, okay? This is a treatment that's been around since the 50s. So obviously between the 50s and now, things have improved a lot in terms of how we deliver the treatment. It's now done fully under general anesthesia, which means that the individual is put to sleep completely. The other thing that's sort of new over the last few decades is now we use a muscle relaxant. The reason is if you've ever seen a seizure happen out in the wild, there's a lot of movement and there's potential for injury to the patient and to others. But modern ECT will involve general anesthesia that puts the individual to sleep and then paralyze the muscles such that the seizure is really happening mostly in the brain. We do see a little bit of it peripherally, but it's happening mostly in the brain. And then it's very carefully monitored. So whomever is getting an ECT, you're plugged to what we call telemetry, so we can monitor your vital signs. And then you're also plugged to what's called an EEG, so that we can see what's happening with the seizure in the brain. Okay, so this tends to be a very quick treatment, really spanning just about 5 minutes. The time it takes to go under anesthesia and have the muscle relaxant take effect and induce the seizure, that's like a 5 to 10 minute time span. And then once the seizure happens, we take about 30 minutes to observe the patient until they wake up and then they're recovered. Some people do it as outpatients and they can go home. Some people are inpatients in the hospital and they can basically return to the unit. So, this might beg the question, how exactly does inducing a seizure, how does that help with anything? So it comes back to where I started is, whenever there are mental illnesses, different parts of the brain, different regions of the brain, the networks are not working the way they should. Sometimes because they're not connecting or communicating the way they should. Okay, so basically there's like a negative neuroplasticity that has happened, or more of an atrophy. And what ECT essentially does is while the seizure is happening, there are a lot of neurochemicals, a lot of neuropeptides that are released. And I give the analogy is essentially like fertilizer for the brain. Okay, so it allows the neurons that were atrophied to start connecting better, start communicating better, and there's better signaling between different parts of the brain. The other effect of ECT is it helps the receptors become more sensitive to the neurotransmitters that are already there. So the implication of this is if you were on a medication and it wasn't working as well, ECT might actually improve the sensitivity of your brain to the medications. Okay, so that's how we believe ECT works. And, like I showed you on the electron microscope, we've done functional imaging studies that actually have shown, these changes that we're talking about. And these are not structural changes in the brain, right? So there's no part of the brain there's one part of the brain that may grow new neurons, but this is really more of a functional change that happens in the brain. The other thing I wanted to mention is how we deliver ECT. So it typically requires initially about 6 to 12 treatments that are done close together. Okay, so this is what we call the acute series. So if somebody comes to us and has very severe treatment-resistant depression, medications are not working, they're very debilitated, they're not functioning, then we would say, okay, let's start the acute series of treatment. And this could look like getting 2 treatments per week or 3 per week. And then we would spread that over about a 6-week period, between 4 to 6 weeks. So that's the acute series, okay? After that, we then wean off the treatment, we taper it off. And then what we need to figure out is this somebody who requires maintenance treatment or not, okay? The reason being, ECT, like I said, it does not change the structure of the brain. It just changed the function, okay? So the implication of that, the flip side, is that those changes actually can and do wear off after a while, okay? So what this means is some people will get their 12 treatments and they will have their depression or their psychosis, whatever it is, go into remission to where they feel almost back to their baseline. But for some, depending on how treatment resistant they are, over time, this wears off to where they need to come for what we call maintenance treatment. And we never know from person to person how much maintenance is required. Sometimes it's every month, sometimes it's every 3 months, sometimes it's every 6 months. But the idea is, once we're able to get you into remission of whatever we're treating, maintaining that remission is something that sometimes requires additional ECT treatments. Okay, so just a little bit more about ECT. What are some of the indications or reasons why we would do ECT? Like I mentioned already, treatment-resistant major depressive disorder. Also bipolar depression is also indicated for ECT. And then the primary psychotic disorders like schizophrenia, schizoaffective disorder is indicated. And then I mentioned catatonia, secondary to whatever the underlying issue is. So these are the common reasons that we offer ECT. I will say that ECT also has an anti-suicidal effect. So sometimes in cases of acute suicidality, in the context of depression, ECT can be indicated for that reason. We also will see people who have depression and what we call failure to thrive. So this would basically be someone who, because of their depression, they're not eating, they're losing weight, and they're actually at risk of dying from the depressive illness. ECT is indicated for that. In terms of reasons not to do ECT or contraindications, we like to say, because it's true, that there's no absolute contraindication to ECT. In other words, there's no one medical condition or no one issue that makes ECT an absolute no-go. But we do have what we call relative contraindications. Okay, and these are mostly due to medical issues. So for example, if someone just had a cardiac event, like a heart attack, or maybe a stroke, a brain bleed type of situation, or they have an untreated arrhythmia of the heart. So things like that could get exacerbated during ECT, we would certainly hold off on offering ECT until that's treated and stabilized. Also severe lung disease, someone who has a pneumonia, for example, would not do well under general anesthesia. So these are reasons to hold off on ECT until a later time. In terms of how well it works, this is still the most effective treatment we have in psychiatry. So there's close to an 80% response rate from ECT. So if you compare that to the slide I shared with you about medications, where it's 30% with the first one, and then it gets progressively lower and lower as we go. So ECT is certainly highly, highly effective. The issue is with the durability, because even though it's very effective and can get individuals out of the depressive episode or out of the psychotic episode, after 3 months, 50% might start having a relapse of that condition. So those are the patients who will require maintenance treatments, like I mentioned. Does this mean everybody, needs to get ECT? That's not the case, because it does have its own side effects. First of all, you're going under general anesthesia, right? And as we know, when anyone is under general anesthesia, you basically lose control of your airway. So we have an anesthesiologist who's doing suctioning to make sure nothing goes down the wrong way. But that's something that could happen, is what we call aspiration, something going down the wrong way. But that's a very rare event. And like I said, we have specialists whose job it is to monitor the airway and reduce the risk of that happening. One thing you might hear about out there is the cognitive or the memory side effect of ECT. So I think this is probably the biggest issue that's out. If you go online and start reading about ECT, you'll definitely read some horror stories about the purported effects of ECT on memory. So the way I explain this to my patients is, first of all, untreated depression and untreated schizophrenia, untreated mental illness in general. This is actually a very strong risk factor for developing dementia in and of itself. So there's certainly the incentive to treat depression as effectively as possible, because apart from reducing quality of life, there's several other medical conditions that will get worse with untreated depression. So that's the first aspect to it. Second aspect is ECT causes a very specific type of memory. It affects memory in a very specific way. So what I mean by that is there's something called episodic memory, okay? And an example of episodic memory is, remembering what you had for dinner last night, or remembering a conversation you had a few hours ago, okay? So what happens in just going back to how memory, the physiology of memory, when we have a new experience, maybe we have a conversation, maybe we go out to dinner, we do something, the memory is not immediately coded into a permanent memory, okay? This might actually happen days later while you're asleep. So memories take time to transition from temporary memories to permanent memories, okay? This is what ECT can interfere with, what's called memory consolidation, okay? So it's not uncommon for someone to come in, let's say ECT's tomorrow, and then they attended this talk. And then after ECT, they have no recollection of the fact that they attended this talk or listened to this talk. So that's an episode of memory that basically failed to consolidate. And then sometimes the memory comes back, sometimes it doesn't. And the same thing can happen with respect to memories that happen shortly after ECT. Okay, so very commonly, episodic memory a day before or a day after ECT, those may be lost. So that's the common type of memory disturbance that happens with ECT. That said, there are patients that we treat that are more advanced in age. And sometimes there's the beginnings of a dementia or some other neurocognitive disorder that's present. So we may find that they experience more than that very circumscribed the day before, day after. They may have gaps in their memories that extend days or even weeks in the past. Okay. But the important thing to keep in mind is it does not affect what we call autobiographical memories, and nobody forgets who they are, where they've been, all their experiences. It doesn't affect procedural memories of the being able to drive, things that have basically become second nature. Those things are never affected by ECT. It's just some of these episodes that can be affected. And again, going back to where I started, treating depression and just weighing the balance, the risk of continuing to live with a debilitating depression that affects your memory anyway is just something to be weighed. So it's sort of a risk benefit type of calculation. Okay. So I imagine I might have some more questions about that. But let me move on and talk about TMS. So TMS is actually very different than ECT because whereas with ECT, we actually want to induce a seizure, a controlled seizure, but a seizure nonetheless. With TMS, that's the opposite of what we want. We don't want you to have a seizure. Okay? So TMS involves, if you can see this machine that looks like a little dental chair up there, we basically apply pulses of magnetic energy and target a very specific structure in the brain. You might have heard of the prefrontal cortex. What we found is that there's a very specific structure that's part of the prefrontal cortex that's connected to other parts of the brain that govern our mood, govern our motivation, our energy levels, and what have you. And if you remember where we started, now we're beginning to realize that the brain is really organized in networks, and the networks are spread throughout different parts of the brain. Okay? So we happen to have access very close to the surface to a structure that's part of that network that controls our mood, our motivation, our focus, and things like that. And we found that if we stimulate that particular structure repeatedly with TMS, something amazing starts to happen. Is that neuroplasticity I talked about. The neurons basically start growing, start communicating better, start connecting better. And that ultimately leads to improved mood, improved focus, improved energy. So that's really the theory behind TMS is, we're able to non-invasively stimulate a very specific part of the brain that's connected to the larger network. The analogy I use is, think about a merry-go-round and or a bus route, and one of the stops is right here. And the bus route is kind of stuck, it's not moving. But if we stimulate repeatedly, the route starts to move better, the communication is better, and then mood improves and all that. So that's the theory behind TMS. The thing to say very quickly about TMS is that it is not a quick treatment. I talked about how ECT, we do 6 to 12 treatments and space it over about a month. Sometimes as quickly as 2 or 3 treatments with ECT, we start to see the improvement, but TMS takes much longer. So we're talking about 6 weeks of treatment with the current protocol that we use, coming in Monday through Friday, and basically sitting on this dental chair looking structure. I'm sorry, my computer is starting. It's pretending. Okay. Yeah, just had to make sure my computer didn't restart. So TMS takes quite a while, about 6 weeks, for us to notice the effects. So it's not a quick treatment. It's more of a very gradual induction of that neuroplasticity we talked about, which is a little bit different than ECT. The upside of TMS is that the effect is actually a lot more durable. Remember, I mentioned with ECT that close to 50% will have a relapse by after 3 months, and then they may require maintenance treatment. With TMS, what we've actually found is that people who either get a very good response or go into full remission, that's maintained for a much longer time, in the order of 6 months to about a year. Okay? So TMS takes longer to work, but the effect might be more durable, and it reduces the need to try new medications. It reduces hospitalizations and things like that. But you do have to be able to come into it's like a clinic setting 5 days a week for about 30 minutes, door to door, to get the treatment. So these are the FDA-approved indications for TMS. So treatment-resistant major depressive disorder is the top reason that we do TMS. And I already defined what it means to be treatment-resistant. You've tried at least 3 medications from at least 2 different classes, right? So this could be an SSRI and an SNRI. Or it could involve using an adjunctive treatment like Abilify, something like that. So 3 to 4 treatments used for long enough, and then also adding psychotherapy onto that. So once you meet that criteria of what we call treatment-resistant depression, most insurance companies will pay for a course of TMS. Okay. It's also approved for adolescents now, from age 15 and up, and also for depression with anxiety. So TMS is not indicated specifically for treating anxiety, but if there's depression with anxious distress, or an anxious depression, TMS can be an option. OCD, obsessive compulsive disorder, is also another disorder that TMS treats. Again, it has to be treatment resistant. You have to have tried a number of medications. You actually have to have tried psychotherapy for OCD. And sometimes a residential treatment of some kind is also required by certain insurance companies. So I'll say the bar for getting treatment approved for OCD is higher, because they do require you to have done some of these levels of treatment. With major depressive disorder, a lot of people, it's like I showed you in that study, it's once you don't respond to the next medication, it's a fairly quick progression to trying 1 or 2 more and finding out they don't work, and then that would meet criteria for treatment-resistant depression. The other interesting indication for TMS is smoking cessation. So that's a fairly recent indication that was added to the portfolio of disorders that can be treated with TMS. But most people end up doing other things before they come to ask for TMS for smoking cessation. But just FYI, it is an indication. Now, you'll notice what's not on here. Bipolar depression is not on here, because that's actually a contraindication, a reason not to do TMS. So that's perfect segue to my next slide. These are the conditions in which TMS is not indicated, meaning, it wouldn't be safe to do it, right? And the first one is a seizure disorder or epilepsy. So like I started with, when I started talking about TMS, the goal is not to induce a seizure because you're in a clinic setting, there's no anesthesia present. We absolutely don't want you to have a seizure. Furthermore, we're only stimulating a very specific localized structure in the brain, right? Seizures happen when the entire brain is stimulated at the same time or firing at the same time. So that's what causes a seizure. So we certainly don't want that to happen with TMS. And if you have a history of epilepsy or seizures in the past, it would certainly be wise not to do anything, even if it's only stimulating a part of the brain. Epilepsy means you have the tendency to have seizures, so we wouldn't treat such an individual with TMS. The other thing that comes up quite often is a history of very severe traumatic brain injury. What this does is it leaves scars in the brain, and that could serve also as a focus for a seizure to happen. So any history of severe traumatic brain injury, concussions, things like that, we have to be careful offering TMS to patients who struggle with that. I mentioned that bipolar depression is not is a contraindication for TMS, meaning we just can't offer it at this time. And the reason is because TMS, at least theoretically, can induce a manic episode. Okay? So if you've ever been told you had bipolar 2 or bipolar 1 or had been manic before, TMS is not currently FDA approved to treat anyone with what we call a bipolar spectrum disorder. I will say that might change because they're doing some more studies. And we very well may get to the point where they'll say, well, as long as you're on a mood stabilizer, you can get TMS. But we're not there yet because, again, theoretically, TMS can induce a manic episode. Obviously, if you have any metals, fragments, devices that can be, altered by the magnet, we wouldn't want to put a big old magnet against your head in that scenario. So those are really the chief reasons why you would not qualify for TMS. The other thing that's not on this slide is current heavy alcohol use, because again, as we know, binge drinking alcohol and then stopping suddenly, that can actually very greatly increase the risk of having a seizure. So current heavy alcohol use, current heavy stimulant use like cocaine and amphetamines, that's another reason why we would hold off on doing TMS, again, because it would increase the risk of having a seizure. Okay? But in the absence of all of those risk factors that I just mentioned, the risk of having a seizure is actually extremely low. It's about 1 in 10,000. So TMS is incredibly safe. It also does not involve any anesthesia, so folks can drive themselves in and drive themselves home after TMS. There are people who work in our hospital, they get their treatment, they can go right back to work. So it doesn't put you out of commission for the whole day. You just have to be able to make it in for 30 minutes, thereabouts, 5 days a week. So most people can find a way to fit that into their schedule. Okay. So this last slide is just a quick note. If you have a family member or you know anyone who you think might be a candidate for either TMS or ECT, we have our Vanderbilt website, Vanderbilt Psychiatry website. And you can certainly, with TMS, we do accept self-referrals. So what that means is you can just pick up the phone and call our coordinator, who's actually on this call, and she'll do a screening, and we'll be able to get your insurance verified and things like that, and then get to see myself or one of my colleagues for a consult. And that's when we ask you all the other questions about your medical history and what have you. So it's fairly, the barriers to getting TMS are, there are not a lot of barriers. You can self-refer yourself and come in, at least to have a consultation. ECT is a little different because we want you to have a primary psychiatrist that's managing your medications. And the reason is because with ECT, usually we tend to offer this to patients with more severe mental illness. And ECT in and of itself typically is not enough. They also need to continue to be on their medications. And by the way, ECT does not preclude medications. You can continue taking whatever it is you are on, except it's affecting the seizure threshold, which we would let you know. But by and large, most people can stay on whatever medications they were on, and then get either ECT or TMS on top of that. The idea being you're basically treating the same thing from multiple different angles, and that might help hopefully get you into remission and improve quality of life. Okay, so that's basically all I had. I'm very, very happy to entertain any questions or comments at this point.
And if you feel more comfortable asking a question in the chat, I can ask it for you. But appreciate it. And I'm going to err on caution tonight and just refer to you as Dr. Tim. And everybody can call me Don. With last names like ours, I'm sure we both experience a lot of mispronunciations. I know I've heard them all on my end. But does anybody have any questions tonight or comments? I always say that the less questions means the more informative the presentation was.
I hope so.
Hey guys, good evening. Dr. Adegoke, thank you so much. Great presentation. I thought it was a really great job of being very clear between the two and the benefits of each. So thank you so much for bringing that. And hopefully some of the students that I sent this to will have been able to enjoy this and saw it as well. So thank you, sir.
My pleasure.
All right, definitely some thanks in the chat. But does anybody have any questions for Dr. Tim tonight? Well, again, it was a very informative presentation tonight. We appreciate you taking the time out of your busy schedule, especially in the evening. You are volunteering your time for NAMI Davidson County, which we always appreciate. But for those of you who are here tonight, Dr. Tim is going to forward me the digital presentation, and all registrants will get an email with that in it. I also will load the audio version of this talk tonight on our YouTube channel. It should be up on our NAMI D Info channel by tomorrow. But everyone who's registered gets my weekly newsletter. In the Monday newsletter coming up on April 27th, we'll have a link to this presentation and other education sessions that we've done. I think we're up to 44 in my 5.5 years at NAMI Davidson County that we've done virtually, that we have on a playlist on our YouTube channel. Lots of different diagnoses and treatments have been discussed over the years, but it's a good, very good primer for mental health conditions that we've got online right now. So with that, I just want I'll do a real quick plug. We have our upcoming NAMI Walks Middle Tennessee on May 9th. Saturday, May 9th, the second Saturday of May at First Horizon Park, the home of the Nashville Sounds. We would love to see you all. It's our biggest community awareness event and fundraiser. We are always interested in teams and registrants, but we're most interested in having the community come out and, as I like to think, take a few walks around the stadium and thumb your nose at the stigma that is still attached, unfortunately, to mental health conditions. We are still fighting that stigma every day. It's lessened over the years, but there's still people who are afraid to come forward with their mental health issues and seek treatments like this when they are struggling. But we want to talk about it and make it and normalize it, because 1 in 5 adults every year in our country deal with some type of mental health condition. And it's important to talk about it and get information and educate yourself. And that's why we have these sessions. I encourage anyone who has any wants or needs when it comes to education to let me know at outreach@namidavidson.org. If I can find a presenter, I definitely will. And when we've been doing this collaboration with Vanderbilt Behavioral Health for over a decade now. It precludes both Tracy and I involvement at Vanderbilt and at NAMI Davidson County, and we can continue it through the years. But with that, I want to thank you again, Dr. Tim, for taking your time tonight. And for those of you who are supporting our programs and our education sessions, we wish you all the best tonight, and take care.